increasing type of pain, aggravated on exertion and relieved on rest. It was associated with palpitations and it was not associated with food intake. History of syncope. For one episode a week ago while lifting heavy object, preceded by dizziness and dimming vision, loss of consciousness for 10 seconds, recovered immediately, not associated with fits, bladder or bowel disturbances. There's no history of swelling of legs, no history of cough with expectoration, no history of right-sided abdominal pain, no history of puffiness of face and oliguria or nocturia, no history of fever with sore throat or joint pain, no history of skin manifestations like rash or nodules, no history of voice change, dysphagia or dyspepsia, no history of cyanotic episodes, no history of recurrent respiratory tract infection, no history of hemoptysis. Past history, no history of similar episodes in the past, no history of rheumatic fever, no history of hypertension, diabetes mellitus, tuberculosis, asthma, thyrotoxicosis, dyslipidemia, seizures, no history of previous surgeries. Personal history, mixed diet consumer with normal appetite, is disturbed sleep, regular bowel and bladder movements, no adverse social habits, and no history of IV drug abuse. No relevant treatment history. Family history, there's history of consanguineous marriage of parents. There's no history of diabetes mellitus, dyslipidemia, or hypertrophic obstructive cardiomyopathy in my family members. No other relevant family history. Summary, Mr. Gopi, a 50-year-old male, came with the chief complaints of palpitations for 6 months, dyspnea on exertion for past 4 months, associated with paroxysmal nocturnal dyspnea, chest pain for past 1 month, one attack of syncope a week ago. Probable system involved is cardiovascular system.
Okay. Just can you analyze symptomatology in this patient? Analyze symptoms. The order of presentation: first the symptom was palpitation, then dyspnea and chest pain, and now patient had a episode of syncope also.
Yes.
So palpitation is the foremost ST, initial ST. Patients are developing it. So, what's your impression as far as the symptom analysis is concerned? You say there is patient cardiac disease. Okay, all many of the symptoms are cardiac symptomatology of cardiac system accepted.
Yes,
And
sir.
first symptom being a palpitation and breathlessness, the chest pain is already presented.
Yes,
So,
sir.
what are the possibility with suspect this patient?
Sir, it has valvular involvement, sir. Most probably aortic regurgitation or mitral regurgitation presents with palpitation as the first symptom, sir.
So, probably you suspect a leakage lesion. Okay, suppose the valvular disease is accepted. If you see valvular disease presenting as palpitation is AR and MR, they will accepted. Why this palpitation AR MR?
Uh, Sir, there's increased force of contraction and it's a high output, cardiac output state, sir. Aortic regurgitation.
But in that case, even anemia, very all aortic output state. Also, they can have palpitation, isn't it?
Yes, sir.
So it is not only the IA output state, it is only a force of contraction, as you rightly said. As far as the patient is having a normal contractile force of the heart is there, then they can have palpitation. Okay, so point here is because palpitation, because of force of contraction. For the
Yes, sir.
person to develop palpitation, there should be pathophysiology. The only three aspects patient can develop palpitation. One is the increase the rate, change in rate of rhythm, change in rate, change in
Yes, sir.
rate of the heartbeat, and
Yes, sir.
one second. கொடுத்துருங்க. ask them to ஆனந்திட்டு கொடுத்துருங்க. எத்தனை பேர் வேணும் பாருங்க.
சூப்பர்விஷன் அகிம்க்கு சொல்லியிருக்கேன்.
PG. PG இருக்கிறதுக்கு
டாக்ஸி அசிஸ்டன்ட் பாத்துக்கிட்ட சொல்லலாம் சார்.
ஸ்குவாட் வச்சுட்டு வருவான்னு சொல்லுங்க அப்போ.
காதான் சார்.
ஹாஃப் அன் ஹவர் ஒரு அசிஸ்டன்ட் பாய்ட்டே போக சொல்லுங்க.
சரி சார், அது பண்ணிருக்கேன் சார்.
ஓகே,
எக்ஸாம் ஸ்டார்ட் பண்ண லேட் ஆச்சுனாலும் யோகேஷ் நான் கலெக்ட் பண்ணி சார்.
கரெக்ட் பண்ணி என்கிட்ட கொடுக்கணும்.
சார் இன்னைக்கு
நாளைக்கு லீவ் தானே.
ஓகே சார்.
கொடுத்தாதான் மண்டே நெக்ஸ்ட் வீக்.
இல்ல சார், கிளினிக்கல்ஸ் நான் இட் வில் பி இம்ப்ளிமெண்டட் லேட்டர். ஊருக்கு போய்ட்டு வாங்க.
ஸோ வாங்கி வச்சு நான் பார்க்கணும்.
2 வீக்ஸ் கழிச்சு கிளினிக்கல்ஸ். நாளைக்கு நானும் சிஓ
எடுத்து யாராவது பார்த்து நிச்சயம் தான் கிடைக்கும் நாளைக்கு. மேடம் சார் இருக்கார், இது ரகுநாத் சார் இருக்கு, நான் ரெண்டு வாங்க நினைக்கிறேன். ரகு சார் இருக்கார். To for the person to develop palpitation, either there should be one of the three components like a rate, rhythm,
and force of contraction.
Okay, these are three factors determine the patient palpitation. So any rate change in rate, it means even sinus tachycardia can produce that right side, and also even a very low heart rate also. Suppose sinus bradycardia also can patient palpitation, especially the patient with a complete thought block, CHP. When the heart rate is less than 40 also they get a palpitation. Here also the force of contraction is more powerful, right? So not only tachycardia, also tachyarrhythmias, even bradyarrhythmia also can produce palpitation. But most commonly, as rightly said, the tachyarrhythmias, tachycardias. Then rhythm, we have arrhythmias. So rhythm means arrhythmias can produce palpitation. It could be commonly, it is extrasystole, premature ventricular contraction or premature beats, the most common cause for transient palpitations. And as you rightly said, the contractile force, we have AR and so with this, when you take that these three parameters in your mind, and we can arrive at a possible cause of palpitation. So and rate, there are so many causes of rate, change in rate, increase rate. Even there are endocrine causes like that. So many causes are there.
Yes, sir.
So in this patient, that was the early presentation. That was early presentation. That's the reason probably you think of valvular heart disease, may probably aortic MR. Okay. The second language patient has is dyspnea is there. Patient is second dyspnea for the first 4 months, and chest pain is also there. So in the setting of chest pain, what do you infer of chest pain? Do you develop chest pain due to AR and MR? How common you get chest pain AR and MR?
It's common, sir. It's common in.
It's common in AR and MR.
Yes, sir.
Oh, how they develop chest pain?
Sir, decreased perfusion, sir. Decreased coronary artery perfusion. There's mismatch in myocardial oxygen supply and demand.
As far as patient is having a normal coronary arteries, they won't develop chest pain. Chest pain due to valvular heart disease, common condition is AS, yeah. So chest pain, valvular heart disease, chest pain is aortic stenosis. Stenosis can produce stenosis. There is a fixed cardiac output status. So there is dependent. Even exertion, there is no increased output. So demand is there. There is no proper adequate blood supply to the heart. That is the cause, reason for the effort angina or indicated in case of aortic stenosis, right? So chest pain, so it is commonly seen in valvular heart disease, aortic stenosis. It's not that quite common in AR because the blood supply is not compromised. Yes. Yes, admin want to say something. Yes. Is there any questions, any issues there? Hello,
Yes,
is
sir.
it audible? Or is it audible or any issues in?
It's audible, sir.
Okay, can you able to hear somebody want to talk in between? The point here is that the chest pain, if you want to link to the valvular heart disease, you commonly see in AS and also see in mitral stenosis with the patient with pulmonary hypertension. So, in the case of mitral stenosis, usually the chest pain is also not a usual feature in mitral stenosis, unless the person develops pulmonary hypertension. Pulmonary hypertension can be chest pain. So for the person developing chest pain, you should know the basic anatomy and his physiology, so that the pain specific structures only can evoke the pain. So in that case, either pericardial disease or myocardial disease can produce a chest pain. So endocardium,
Yes.
we know, is pain intensive. So in that case, vasculature, the proximal major vessels or pain sensitive. Suppose the pulmonary hypertension is dilatation of pulmonary artery can produce chest pain, right?
Yes,
Increase the
sir.
pulmonary pressure can chest pain. Otherwise, mitral stenosis usually or that also doesn't produce chest pain, not commonly seen unless the patient develops pulmonary hypertension, right? And they can develop chest pain due to any other maybe since we're discussing symptomatology, is there any other way picking up chest pain mitral stenosis?
Sir, coronary artery disease.
Associated, very good. So that's always should be included in any discussion. So associated CAD for any patients, whether they can have the combination of diseases, valvular heart disease, and they can have hypertensive heart disease and CAD, these combinations. So
Yes,
not
sir.
only the valvular heart disease, they can have especially hypertensive heart disease is common. Hypertension patient can have hypertension also. So in that case, they can have a chest pain also accepted. And as you said, mitral stenosis, the patient of chest pain because of associated CAD accepted. Any other type of chest pain, mitral stenosis?
Sir, it could be of pleuritic origin or psychological and anxiety states also, sir.
Pleuritic, due to what?
Pulmonary embolism, pleuritis,
Yes, go very good. So
pneumothorax.
yes, as a complication of pulmonary embolism, infection, the associated features like the where thrombus in the left atrium, Lelia thrombus, which can be, or the thrombus also placed in the right atrium. Also, you know that. So the both atrium is fibrillating. So the person develops pulmonary embolism because of some clot in the right atrium. It can produce pulmonary infarction. The pulmonary infarction, they can develop a chest pain of fluid, as I said. So they may have it's a pleuritic type of chest pain. It can occur in patients with mitral stenosis when they develop a pulmonary infarction, right? So right. So that's what you should know the basics of structures of the heart and its connections or major vessels which are pain sensitive. The pericardium is pain sensitive, or the patient develop infarction also can develop, the common vasculature and pericardial disease, so the pericardial disease, and myocardial disease, is because of ischemia the arteries can produce, and major vessels are pain sensitive. Otherwise, majority of other sections are pain sensitive, right? Okay. So
Yes, sir.
this patient developed chest pain and probably developed recently an episode of syncope also. Probably maybe having associated AS also, we don't know. So this presence of these two symptoms like chest pain and syncope and indicates that patient may be having some obstructive lesion at the aortic level also. Right?
Yes, sir.
Since you say the AR could be the reason for the palpitation in this patient, the presence of chest pain and syncope is not a common feature of aortic regurgitation doesn't produce. You don't get the syncope
Sir,
and chest pain usually due to
sir, there could be associated aortic stenosis,
yes,
sir.
that's what we have to analyze at the stage. So could be there's associated AS also, probably predominantly may have a regurgitant lesions. So what is the patient age?
50-year-old male, sir.
50-year male patient. Was there any positive history of any rheumatic fever or hospitalization for rheumatic heart disease?
No, sir.
No. So the patient is having a first episode, the 50-year-old. Is how common develop valvular heart disease in this 50-year-old? Rheumatic you think rheumatic heart disease is common in this age group or still younger age group?
Sir, rheumatic heart disease usually has mitral valve involvement also, sir, along with aortic regurgitation.
Yes,
But
yes, sir. Yes.
in this case, there's mitral valve involvement is not there, sir.
No, we are knowing the history. So you say the valvular aortic is, you say could be MR and AR, both it could be either of this one. That's what you say, AR and MR.
Yes, sir.
And 50-year-old male patient, right? So what is the possible heart disease suffering? We want to say it's a now at this stage we have discussed various symptoms one by one, combined together, patient palpitation and breathlessness, chest pain, and syncope. So, taking everything together, patient age is 50-year-old of insidious onset. Patient has got features of cardiac failure, and so 50-year-old male patient. So,
Sir,
what is the possible heart disease suspected?
the patient is presenting with complaints of severe aortic regurgitation with aortic stenosis, sir. So it could be possible congenital bicuspid aortic valve, sir.
Suppose if you suspect valvular heart disease patient is quite unlikely rheumatic. Okay, so it unlikely rheumatic. As you know, the age of onset is quite a younger age group, right? So first point here is that you want to take up it's a valvular heart disease. In that case, you want to put it as a aortic valvular heart disease, isn't it? So
Yes, sir.
unlikely is mitral is accepted. So apart from a valvular heart disease, do you want to bring in any other heart disease this scenario? Do you want to bring in only valvular heart disease, or could be anything else? Can it be myocardial heart disease? Can it be because of the patients? Can it be only uh, uh, patient heart disease because of the involvement only myocardium? Can it be coronary heart disease alone?
Uh, Sir, there could be a cardiomyopathy also, sir.
Yes, yes, could be, but in that case, usually yes. So it could be a myocardial heart disease also. Could be a myocardial heart disease also. So in that case, usually the dyspnea is a predominant presentation. If you suspect is a cardiomyopathy, dilated cardiomyopathy presentation is usually they will have severe biventricular hypertrophy, so severe breathlessness, PNT will be there. And if it due to coronary heart disease causing cardiomyopathy, the ischemic cardiomyopathy, they can have chest pain also, right? So, or patient could have had the silent event, so palpitation could be some arrhythmias could have precipitated the pain cardiac failure, and that line also can discuss. Okay, so uh, not only it is the valvular heart disease, is you can also equally think of a myocardial heart disease also. Age is 50 years, right?
Yes, sir.
So most common is usually what you see is a uh, myocardial disease. Could be a coronary disease or coronary disease causing myocardial damage, or could be a primary disease of myocardium, as you said, is a cardiomyopathy. Also, could be the underlying cause. We don't know still. Okay, so we'll examine and find out what's exactly the clinical features. We'll discuss now. Just go to the examination.
General
Yes.
examination. Consent was obtained before examining the patient. Patient is conscious, alert, and well oriented to time, place, and person. Patient was moderately built and moderately nourished. Bilateral pitting pedal edema present. No pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy. Pulse rate 87 beats per minute. Rhythm regular. Volume high volume collapsing pulse. Pulses bispherians felt. Locomotor brachii felt. All peripheral pulses felt. Vessel wall not thickened. No radial or radiofemoral delay. Blood pressure, left upper limb 136 bar 60 millimeter of mercury, right upper limb 132 bar 60 millimeter of mercury, left lower limb 158 bar 70 millimeter of mercury. Pulse pressure is 76 millimeter of mercury, indicating wide pulse pressure. Hill sign is positive. Respiratory rate is 22 per minute, regular abdominothoracic. Temperature is afebrile. Jugular venous pressure is not elevated. Examination of cardiovascular system. Inspection. Chest wall appears symmetrical. Trachea appears to be in midline. Suprasternal pulsation seen. Apical impulse visualized at left sixth intercostal space, 1.5 centimeter lateral to mid-clavicular line. Epigastric pulsations seen. No venous engorgement, precordial bulge, sinuses or scarce pain. Palpation. Trachea confirmed to be in midline. Hyperdynamic apical impulse felt in left sixth intercostal space, 1.5 centimeter lateral to mid-clavicular line. Suprasternal pulsations and epigastric pulsations felt. Systolic thrill felt in aortic area, best felt in full expiration with patient sitting and leaning forwards. Carotid thrill present, parasternal heave absent. Auscultation. In mitral area, S1, S2 heard, normal intensity, no murmur. Aortic area, S1 heard, single S2 heard. High-pitched crescendo-decrescendo ejection systolic murmur, grade 4, heard with diaphragm of stethoscope and with patient leaning forward and breath held in expiration. Pulmonary area, S1, S2 heard, normal intensity, no murmur. Tricuspid area, S1, S2 heard, normal intensity, no murmur. Examination of other systems. Respiratory system, normal vesicular breath sounds heard, no abdominal sounds heard. Abdomen soft, non-tender, no organomegaly. CNS, no focal neurological deficits. Diagnosis. A case of valvular heart disease in the form of severe aortic regurgitation and accompanying mild to moderate aortic stenosis, with probable etiology being bicuspid aortic valve. The patient is in sinus rhythm, has left ventricular hypertrophy with signs of left-sided dysfunction, with no signs of pulmonary hypertension, and without endocarditis complications.
Okay. So we'll take up one by one general examination finding. What is general examination? So what are the positive signs you have made out?
So there's bilateral pitting pedal edema, sir,
Okay.
indicating left-sided dysfunction, left heart.
So pitting edema indicates left heart failure, right heart failure.
Sir, it could be both.
Congestive cardiac failure. So
Congestive cardiac failure.
right heart failure, dominant heart failure only. Dominant right heart failure. It can occur in left heart failure. They develop pulmonary congestion, isn't it? Left sided heart failure, they develop
Yes,
pulmonary
sir.
congestion, and right heart failure, yes, pedal edema. The triad of right heart failure is right JVP, tetrahepatomegaly, and pedal edema, isn't it? So
Yes,
then you diagnosis, you have to say it's congestive cardiac failure. Okay,
okay, sir.
right?
Okay, sir.
So now you have put it as left side failure only. But period edema usually is the feature of right heart failure. How can left heart failure produce period edema? How come unless the patient develops venous congestion, isn't it? So increased capillary pressure is the reason. And how this pathophysiology happens, if at all, if you say it is a left side heart failure. Left side heart failure can
No.
rise to increase the pulmonary
So
venous pressure, isn't it?
yes, sir. Maybe it's progressing towards right heart.
Progressive. Because right side also, right side heart could not maybe some events has taken place recently, so right side heart not able to cope. That's what the fates. Yeah, that's what we have to put it as. Or if you want to bring in the pedal edema due to some other cause, that's a different issue. Then when you say it's the pedal edema is there, also look for the other signs. Software have that failure in the form of either the JEP is elevated or tender epidemic. Okay. If
Okay, sir.
these three signs are there, then it's definitely it is a right heart failure, isn't it?
Yes, sir.
Okay. So our patient may be on treatment. So in that case, edema may be persisting only in the patient walks like that, or okay, and the patient maybe disappears. The patient go to bed and the early morning when the patient wakes up, the pedal will disappear. All these could be due to part of the treatment. Diuretic is going to disappear, isn't it? So otherwise, the epidemic congestive liver also could disappear following a treatment, right? So we
Okay,
have
sir.
to say that there is patient having a congestive cardiac failure is a additional That not left something you said left side dysfunction. All the steps you avoid. Don't write dysfunction, malfunction, hyperfunction. Okay.
Okay, sir.
Just coin the term what is given in textbook. So either right
Okay,
and
sir.
congestive cardiac failure, left heart failure, right heart failure. All this should be written. Okay.
Okay, sir.
Right. So general examination, you have said positive sign being is there any evidence of okay conscious, alert, well oriented, nothing contributory, no cyanosis, anemia is not there. Right. Next, vitals are pulse rate is 87 and is regular and is live large volume pulse, large volume collapsing pulse. Right. You mentioned
Yes, sir.
pulses dyspharia is felt where.
Sir, it's present in aortic regurgitation
That's what, which
accompanied with
present all
aortic
the pulses
stenosis.
present you be able to feel or which pulse specifically look for pulses dyspharia?
Sorry, sir.
No, no, which pulse you checked it for pulses dyspharia?
So brachial artery and femoral artery, sir.
Femoral. Any character better to look at only at the proximal arteries, carotid, carotid or brachial,
Okay, sir.
isn't it?
Okay,
Can
sir.
be felt other areas also, but even you can feel the dyspharia in perineal also, but usually any character is better to palpate the proximal vasculature. There's a dictum, except there may be exceptions, like
Okay,
collapsing
sir.
pulse, pulses alternance, all those can happen. But usually, we have to clinically, when you want to find out any special character, you have to palpate the proximal vessels and preferably carotids. The better site to look
Okay,
for
sir.
the pulse character. Also, biceps also you can say, right? Okay.
Okay,
So
sir.
you feel there is a pulse is dyspharia, that means there's twice beating pulse, isn't it? Twice beating. You can feel the two two waves are felt, isn't it? That's what I want to say,
Yes,
right?
sir.
So what are the waves you're feeling now?
So two peaks in one systole, sir.
Yes, yes. So what are the waves
So
you feel?
first is due to rapid ejection of blood into the aorta. So it's a percussion wave. And second one is tidal wave, sir. It's the
Yes, P.
reflected waves from the periphery.
Exactly, right. So PT, so it's a percussion and tidal wave or felt in a systolic phase. Systolic
Yes, sir.
phase, right?
Yes, sir.
And twice beating pulse is always called a twice beating pulse or bifid pulse, whatever the terms you can say.
Okay, sir.
And what does it indicate? Pulses this variance. Uh, does it indicate? What does it indicate? What are the cause of pulse
Uh,
dysphagia?
so severe aortic regurgitation or aortic regurgitation with aortic stenosis. Or it could be also due to hypertrophic cardiomyopathy.
Good, good. So three causes, as rightly said. It is usually a combination of AS and AR. That is predominantly usually AR dominant. AR, you can say the significant AR with associated MS can get a pulse disvariance or gets only severe AR. Third point, as you rightly said, the HOCM, hypertrophic cardiomyopathy. All these produce a bifid pulse and pulse disvariance. There's one more type of pulse also it is there where they can get two peaks. What is pulses
So
dichroticus?
pulses, yes, sir.
Pulses?
Dicroticus, sir.
Yes, yes. What does it indicate? What does it mean?
So there's uh, two peaks, sir, but one is in systole and one is in diastole, sir.
Exactly. So you are right. So pulse dichroticus. So you can there always be simultaneously. You ask it also. Suppose if you are in that case you can confirm whether it's which the two tough what to say it is confined to systolic phase, diastolic phase, right? Okay.
Okay, sir.
Yes, okay. So better all these characters are better you confirm it by the pulse tracing. Is it suppose it is difficult for you to clinically palpate, you can always
Okay, sir.
do what is called pulse tracing and can find out what exactly is the nature of the pulse wave also. Right. So so experience is there and patient is having what is systolic BP in this patient?
So 136 bar 60, sir.
36 percent.
136, 136.
So 60 is a phase 4 or phase 5 correct of sound.
phase 4.
Stage 4, phase 4. Right, exactly. So use always phase 5 as a diastolic phase, except this situation where you use a phase 4. Yeah, phase 4. Huh?
Yes, sir.
So there's a situation you use always phase 5 as a diastolic pressure. Few situation where the difference between the phase 4 and phase more than 10 millimeter mercury, you always say the muffling of heart sound, not disappearance. It's muffling is a stage. It's a correct of sounds fourth stage. That is
Yes, sir.
taken as a diastolic BP. So all the others can note this point that whenever we record the BP, so phasing is also important. You know the how many phases are there? 25 phases. So diastolic, the disappearance of the correct of sound is a grade 5 and stage 5, and the muffling is a fourth stage. So many situations you use a phase 5 as diastolic. When this disappears, will take it. Whereas not any patient, the patient want to check the blood pressure of the patient who is hypertensive, when you take the recording and the disappearance is taken as a diastolic blood pressure. The 5 situations where there is these two difference beyond 10 mm mercury, you take a muffling. This case, because the phase 4 and phase 5 can extend even up to 0 also. Understand? Understand?
Yes,
So that's what we have to say. Can also you can say there is a phase 4 of a product of sounds also you can mention to the degree. And what is the systolic pressure? You say it's only 136 or 130 you're telling. So what do you infer from this systolic pressure? What is the comment on that? You are made a
sir.
diagnosis at the end. Also, you said the diagnosis. Has it got anything important to do with the diagnosis with regard to your systolic blood pressure?
Um,
Yes, ma'am.
there is increased end-diastolic volume, sir, and
Okay,
there
okay,
is
that's fine.
increased.
Okay. We are discussing about a systolic pressure. This patient around less than 140. So when the national BP is 60, we expect a systolic BP should beyond 160 or 170, 120, like that, 180 like that. So you don't see
Yes,
the
sir.
proportional rise systolic pressure. The physiologically, if you see, the diastolic drop in BP is the foremost important finding in AR accepted. Okay. The diastolic fall in BP is the foremost pathological event what occurred in AR. At the same time, we expect a systolic pressure should be high. So is the white pulse pressure is due to two components. One is because of the increased systolic pressure. Second is the diastolic pressure drop. Right.
Yes,
Right.
sir.
So, but predominant feature in AR is the by the diastolic runoff. So that case the diastolic BP, as you said, is 60, but proportionately you expect a systolic BP also to go up, right? So in this case,
Okay,
there is
sir.
no proportional rise in systolic BP. That's the point I want to stress in this newer page recording is that this indicates there is some obstructive lesion aortic level, right? Understand? So this is indirect
Yes,
evidence.
sir.
This is called as a systolic decapitation. This is called as a systolic decapitation. So you expect
Okay,
a
sir.
systolic BP little bit higher, but in this patient it is not so. So it is only less than 140. So indicates that there is a systolic decapitation. This gives a clue that there is a always associated outflow tract obstruction aortic level. So there must be AS also. There's a clue for the AS in this patient. Okay, as far as the BP is
Yes, sir.
concerned, the clue what you get it from the measuring the systolic BP is that there is associated AS also, right? So that's a important clue because when we go to discuss later also we'll go to have some discussion about the MAMR. So when you that sends this finding. There is what is called the systolic decapitation. This says there is organic case, right?
Okay, sir.
So it's one of the important evidence of the organic additionals, right? So we don't understand the very important valid point to be discussed. Okay,
Yes,
then
sir.
go to the other pulses also. Felt lower limb pulse felt. There are many signs are there. Lower limb BP also supposed to measure in this case. But for hill signs, all those also to be discussed. Anyway, you will not measure the lower limb BP in this patient. Huh?
Sir, I
Yeah.
have mentioned, sir, left lower limb is 158 by 70 millimeter of mercury.
Okay, okay. Right, okay.
Yes, sir.
So respiratory rate, everything normal, and JEP is not elevated. Yes. Inspection, chest is symmetrical, and trachea the midline. You can see the suprasternal pulsation is seen. So whenever is suprasternal pulsation, what do you infer from that? There's a pulsation seen of the suprasternal region.
Sir, aortic regurgitation, sir.
Yes, any other condition?
Aortic arch aneurysm.
Good.
Coarctation of aorta.
Very good, very good. So at least remember these three conditions what you rightly said. AR, aortic aneurysm, and coarctation of aorta. So you can see the suprasternal pulsation. Right, okay, and then. So inspect, you said the apical impulse procedure, the sixth place deviated down and out.
Yes, sir. Indicates left ventricular hypertrophy, sir.
Okay. Okay, next slide. Epigastric pulsation also you think it because of high output status, isn't it?
Yes,
Epigastric
sir.
pulsation, this patient, do you think it's because of RVH or epigastric pulsation?
So epigastric pulsations.
There are many kind epigastric pulsation. He is very concerned about a side of RVH also.
Yes, sir.
You have to be
Okay,
very
sir.
careful whether it is which area you can feel, whether the expansion pulsation or transfer pulsation like that, like aortic pulsation. What you see the epigastric pulsation is the aortic pulsation. Okay.
Okay, sir.
Thrill in the aortic area and just felt in the full expiration. Patient sitting and leaning forward. Aortic area means first aortic area. Carotid thrill present, parasternal leaf absent. So the thrills are the
Aortic area.
first aortic area. Okay. Percussion not done. Go fast contation. Yes.
In aortic area, S1 is heard and there is single S2 present, sir. And ejection
What do you
systolic
mean?
murmur.
What do you mean by single S2? You
So
hear
only
a,
it's only A2 or P2, sir. Either one of them is
which is
present,
heard
sir.
now.
Sir, it could be due to aortic stenosis if A2 is absent.
So you hear to absent. You want the A to absent?
Yes, sir. Aortic stenosis
You
can be
return normal
present.
intensity again. Again you return normal intensity also.
Yes, sir.
Yeah. In the mitral area, normal is put and aortic area S1 is heard, S2 is single.
Yes, sir.
Okay. Do you hear two hot zones in aortic area normally?
No, sir. There is a split. Uh, there is a split in certain conditions, sir.
No, my question here is
Yes, sir.
usually the first hot zone is better heard in the apex, the second hot zone is better heard over the base. This point you know that.
Yes,
Here,
sir.
and you say there's a S2. When we discuss about S2, the sounds you hear the two component in aortic area, or where do you hear the two components? Aortic
Sir,
component and
during
pulmonary.
expiration,
Yes.
during expiration, sir,
Which
physiological
area? Which area? Which area?
in the aortic area,
The
sir.
Oh.
Sorry,
second left
pulmonary.
intercostal.
Yes. Usually, when we talk about spit and everything in the pulmonary area, isn't it? So, can a pulmonary component is best shared in the pulmonary area, isn't it?
Okay, sir.
Isn't it? So, when we discuss about spitting, wide spitting, narrow spitting, all those, you have to have the two components, pulmonic and aortic component. So, both the components are normally heard well where? In the pulmonary area, isn't it?
Okay, sir.
Yes or no?
Yes, sir.
Sir,
So,
is it
pulmonary
possible to get splitting during inspiration?
yes. Yes, that's
Okay.
what you will get. Spitting can be best heard in the inspiration. But where do you auscultate for spitting?
So
Which
second
area?
intercostal space left
It's
side.
pulmonary area. Isn't it? This is pulmonary area.
Yes,
This is
yes.
pulmonary area. So we'll discuss about the spitting of second note sound and about two components if you want to test. Specifically, the best place you are supposed to auscultate is over the pulmonary area. Okay.
Okay,
And
sir.
maybe you can say A2 is soft, you can say. Suppose when you auscultate the aortic area in your case, S1 is to hard, you can say S2 is soft.
Okay, sir.
Okay. In that case, if we assume that it is only A2,
Okay, sir.
right? Don't bring in single means usually very difficult to hear splitting in the first aortic area. Okay. Understand my question? Understand my point or not?
Okay, sir.
See, the
Yes, sir.
pulmonic compound of the second outsound usually they confine to the second area, this pulmonary area. Only patient develops pulmonary hypertension, the pulmonary component can be heard in third space or rarely in the apex also. You understand? So usually, the pulmonary component of the second outsound and aortic component of the second outsound both are here in the pulmonary area. Okay,
Okay,
that
sir.
point is clear now. So, when the person is having a pulmonary hypertension, P2, that's why P2 is loud, palpable, and it can be narrow spit. So many findings of pulmonary hypertension may develop. So, we discuss about the P2 events in the pulmonary area, right?
Yes,
When
sir.
it comes to the aortic area, usually you don't discuss about splitting in there. Okay,
Okay, sir. Okay, sir.
right? So
Uh,
usually the pulmonary components are not usually heard in the aortic area. It's usually many is confined to the pulmonary area. So in that case, the sound what you hear is predominantly it is the aortic component of second heart sound only. Okay, what you hear in aortic area, first heart sound, first aortic area, that is the second right intestinal space. So the second heart sound what you hear is predominantly by the aortic component only. Okay, so if it
okay,
is
sir.
soft, it means the events of the aortic event. But loud also indicates the aortic event. So its softness indicates there is a aortic stenosis or aortic regurgitation. Both can produce a soft depending on the underlying cause for the disease. Understand? So what
Okay,
you
sir.
expect is in this case, better you say whether the normal intensity of A2 or it is soft or it is loud. That's the point we have to highlight.
Okay,
Okay.
sir. Okay, sir.
So in this patient, you put a single, so we have to very care, and is normal intensity or decreased intensity?
Normal decreased
Normal,
intensity should be present, sir. Hmm.
decreased intensity. So now it is soft, you can say, right?
Okay,
S2 is soft, you can say, but it means A2, right? Okay, right. Next,
okay, sir.
there is a murmur also discussed. What's the murmur discussed in this patient? Great.
Ejection systolic murmur, sir.
4/6 murmur, which is heard in the first neck of space, now the connect to the current also can see. Yeah.
Yes, sir.
Then, the other murmur is there?
No, sir.
No other murmur. So, you can able to hear ESM murmur in the first aortic area.
Yes,
Pulmonary
sir.
area is normal, text area is normal. Then what is? That's all.
Yes, sir.
Go to the next one. No, previously, everything, previously. No. Auscultation only. There is high pitched crescent or decrescent ESM member. Okay. What else is there for the diagnosis, for your diagnosis?
That's it, sir.
Yes, ma'am?
Auscultation only murmur is heard, sir.
Only mama is the ESM member.
Injection, yes, sir.
There's the diagnosis only AS now.
So there could be early diastolic murmur also, sir.
That should mention, ma'am. That is a feature of AR. Yeah. We have to have AR member. Yeah. So carefully auscultate the second aortic area. You have to mention now. You have to, for a case, predominant finding what we say is a pulses disferience is there. So it indicates there must be some AR should be there. The sign of AR is a early diastolic murmur, which is showed in the second aortic area, otherwise called a left third intercal space, otherwise called ERPS area. So this area is supposed to ask carefully. You have to examine the patient silent room. You have to keep the patient breath held in expiration, leaning forward. Right?
Okay, sir. Okay, sir.
Silent atmosphere should be there.
So when there is a combined aortic valve disease, systolic murmurs are better heard.
Okay, better head, but ADM also should be heard.
Okay, sir.
You have to have the
Okay.
ADM to say diagnosis because since you have other signs of AR, like there is
Yes,
a
sir.
prominent finding is that there is a large volume collapsing pulses, buses, variants,
Yes, sir.
there is supraspinal pulsation, everything is there. That means the AR is there, isn't it?
Yes, sir.
Break our tea in the room. So
Okay, sir.
AR is there.
Okay,
Understand?
sir.
So we have to have some ADM moment should be heard in the can be heard in the first aortic area or can be second aortic also, but you have to concentrate and listen. Is it? And you have to make out the murmur also. Okay, there is a diagnosis you
Okay,
want
sir.
to say. Murmur will be there. Okay. But the problem here is that the A2 may be soft one, sometimes very difficult for you to hear is a distinct murmur. Sometimes, since you are hearing the systolic murmur and both decrescent or decrescent murmur, some people may take that as a the decrescent murmur could be mistaken. Also, they may not, they may think it's only a ESM, but it's only EDM murmur. Like that, you have to palpate always. We have to always palpate. We have to palpate also so that any other event you are hearing, the simultaneous auscultate, and is there any event that is distinct from the pulse? Okay, when you auscultate, if you can able
Okay,
to
sir.
hear some murmur which is not coinciding with the pulse, it is diastolic event, right?
Okay, sir.
So when you hear the two murmur, we have to be in a push to differentiate these two, or we should find out additional finding, right? So EDM is the mandatory finding, right? Next, yeah, for
Examination
diagnosis,
of other systems. No
diagnosis,
findings. Uh,
yes.
di- Valvular heart disease in form of severe aortic regurgitation and accompanying mild to moderate aortic stenosis.
You can need not accompanying, not accompanying. All these words should be avoided. So you say diagnosis of the patient. Diagnosis is a bad valvular heart, valvular heart disease.
Okay.
I
Okay, sir.
will put AR as a first, like I rightly said, but I say AR, this is severe AR, there should be definitely EDM. Okay.
Okay,
So
sir.
you can put aortic regurgitation with, you can say aortic stenosis,
Okay, sir.
severe aortic regurgitation, and you can say mild or moderate. Okay. But either use either mild or moderate.
Okay, sir.
Cannot write both. Mild to moderate all not acceptable. Better
Okay,
you
sir.
put just AR and AS. Don't mention
Okay,
about
sir.
severity now. Now, as undergraduate level, just write aortic regurgitation and aortic stenosis.
Okay, sir.
Okay, valvular, that's a valvular heart disease. And etiology is big, probably etiology is bicuspid valve and patient sinus rhythm. No need to write definitely hypertrophy and all.
Okay, sir.
LVH is diagnosis. No, not diagnosis. LVH is the finding.
Okay, sir.
Don't bring LVH now. Delete that. So you can write patient is having but maybe by heart failure, like congestive cardiac failure can write. Sinus
Okay, sir.
no pulmonary hypertension. That you should modify that. So as you rightly put the first, if you write the first is the AR, that means it's dominant. Okay.
Okay, sir.
Obviously, in your case, AR is dominant. No dispute about that. Okay.
Okay, sir.
And
Yes, sir.
first you make a diagnosis which is safer for it. Don't bring in so many complicated issues like mild monitor. So right, valvular heart disease, aortic regurgitation with aortic stenosis. That
Okay,
means it's
sir.
organic. Okay. When you write aortic stenosis, that means organic lesion. Right?
Okay, sir.
So right, okay. So for you, just a few discussions about for the 10 minutes. And
Okay.
etiology accepted. There's only a isolated aortic event, so unlikely it's dramatic. So you bring in a BAV is a possible underlying condition. Is there any other clinical sign favors diagnosis of bigus radicals case?
Uh, Sir, there's nothing present in this patient, sir, but
Hmm.
the bicuspid aortic valve is most of presence in fifth to sixth decade, sir. So,
Okay.
and
Okay. Just one more or two points I want to add. Since your diagnosis of bicuspid aortic valve is made now, how does this differ from rheumatic etiology?
the rheumatic, there is a past history of infection to
Okay, all
rheumatic
those are
fever, sir.
don't worry about past history is there, mitral involvement is there, PH, all those leave it. At this point, your examination point. So, what are the exam in science, exam in physical science that differ from the rheumatic? That's also can produce rarely 10% individuals, only isolated aortic valve also can be involved in rheumatic. Okay, this point also should remember. It doesn't
Okay,
mean that
sir.
always
Yes,
there
sir.
will be a mitral and all
Yes,
the
sir.
8% is also there, but there are exceptions are there. But that this is a point. But as a physical science we elicited, with that you have to say we should say which is the finding that favors rheumatic or is a back Okay, so in a case of rheumatic, usually the A2 will be soft always. The A2 will be soft. It's a
Okay, sir.
problem is in the valve. So valve. So
Okay, sir.
valve is got distortion. So many things takes place. So and fibrosis can take place. So A2 will be always soft in a rheumatic scenario, right? Okay. Whereas in
Yeah.
bicuspid valve, usually normal, right? Usually bicuspid second order is usually normal. And since the bicuspid, the two cusp are there, so opening will produce one particular sound. Opening of the
Ejection click.
valve, yes, exactly. Good. So opening step will be here as a ejection click, which is the systolic event. It is a systolic event here
Okay,
after
sir.
the first order zone, right? And is many times best shared in the apex. That point I want to stress. So ejection click is the added sound which is heard in the ejection phase of the systole and is best heard in the apex of the heart. Some reason. So it may make clear you are having a loud S1. Okay,
Yes, sir.
suppose because it happens after the immediately after the first order zone. So, reporter, Andrikara, அவரா பேஷண்ட் பையனா எங்க இருக்காரு ஹாஸ்டல் குறைச்சு குறைச்சலும் பதில் பேசிட்டு குறைச்சு காசு முடிக்க போறோம் உள்ள குறைச்சோம். So you have to differentiate whether the lesion, whether it is a is due to a bicuspid valve or rheumatic. Rheumatic. So in that case, so
Okay, sir.
for 5 minutes, sir, class முடிச்சிடுறேன். Class. So in that case, so when you auscultate in the mitral area, the ejection phase, you can hear one additional sounds, and that is a ejection click. Okay, that may denote that patient may be having a BAV is the underlying cause for the AS and AR. Okay, so sometimes
Okay, sir.
it can be, suppose when you vascular vital area, the sound may be first out sound, maybe you may think that is because the EC occurs in the immediate phase of ejection phase. So the first out sound and the EC maybe as though it's clubbed together, and you can hear it's maybe interpreted as a loud yes one. Okay, so
Okay,
normally
sir.
any case of patient with dramatic aortic in hospital, in the hospital or the mitral area, the first outsound usually normally will be soft. In
Okay,
situation
sir.
where if you hear the first outsound, if you feel it is loud, then could be a underlying, it could be associated AC is there. So in that case, the underlying cause should be a bicuspid valve, and simultaneously concentrate over the A2 also. A2 will be also normal. A2 will be normal in that situation, right?
Okay, sir.
So that's why you have to differentiate as far as you were just for completion's sake. Just I have discussed this case. Okay.
Okay, sir.
So diagnosis, rightly said, is the first diagnosis. First, you have to put the dominant lesion AR, and there is a organic AS also. So this is when you put AS, it means the organic. So in your
Okay.
case, the aortic stenosis is. Do you want to say it is the organic or functional? You can get a ESM murmur in the aortic area because of only AR also, isn't it?
Okay, sir. Yes.
Yeah, so only AR itself also can produce a ESM murmur. Only severe aortic regurgitation. Also, because what happens is the flow into the left ventricle is more slow, so the force of contraction and also stroke volume will increasing. So it produces a flow murmur across the aortic valve, the ESM murmur. Okay, so
Okay,
that
sir.
also you should know that there is a ESM murmur which is a functional ESM because of the flow, increase more flow across the aortic valve can produce a functional AS. But in your case, there is a thrill is there, right?
Yes, sir.
So also grading a murmur, you put it as it's more the 4/6, and BP already we discussed before. The BP is 136 only systolic. So all these three factors denotes there is a organic, right?
Yes,
Okay.
sir.
These are points to be discussed. And any questions by anybody, you can. Investigation, right? Echocardiogram will be confirm the diagnosis.
Yes.
Treatment, we have to treat the
Aortic.
patient with symptomatically you give some like treatment for cardiac failure. Has to be done. Okay.
Okay, sir.
Any questions, are there?
Sir, one doubt, sir.
Yes, yes.
Sir, can there be signs of right heart failure with no pulmonary hypertension in an aortic regurgitation or stenosis case? Sir?
When full tea pot.
Sir?
நான் குடிச்சிட்டு குடிச்சிட்டு உட்கார ஃப்ரெண்ட் வாங்க காஃபி கொஞ்சம் கொடுமா சார்ப்பா. Yes, but some like this patient had some palpitation also, some arrhythmias can precipitate. Usually, the pulmonary hypertension develops in the case of mitral heart disease. Okay, some events which can precipitate left heart failure also can cause right heart failure, but the onset of congestive cardiac failure, it gives a worse prognosis. It need not always pulmonary hypertension should be there. In the
Okay,
case
sir.
of aortic valvular disease, okay, usually pulmonary hypertension usually not a feature. It's common mitral heart disease. But at the same time, patient need not develop pulmonary hypertension to have right heart failure also. Okay.
Okay, sir. Yes, sir.
Right. Okay.
Thank you, sir.
Okay. Any questions there? Then we'll conclude. Okay. Tomorrow. Monday I'll have class. Monday 8:45, 8:30, 8:45. Okay. The presenter can prepare any case.
Okay, sir. Thank you so much.
Okay. Right. Okay.
Thank you, sir.
Okay. Now, Mama. Okay. That's it, man.